So good evening, everybody. We have a case by Dr. Vivek Goyal, Ganga Ram, and the faculty is Dr. P.P. Verma from Primus Hospital and Dr. Sagar Gupta from Metro Hospital, Faridabad. Dr. Vivek, it's all yours.
Thank you, Puniji. Good evening,
I
respect.
think I must also welcome all the students. It's long time we met and things are improving. The days are improving. The COVID is on a downslope. I think the time may not be very far when again the physical interactions could be there. And today we have got Dr. Vivek Goyal. He's presenting the case. I request him to go ahead. And Dr. Sagar Gupta is already there. He is a colleague faculty. Yeah, please go ahead.
Good evening, respected teachers and my colleagues. I am here to present today's case. So with your due permission, may I start, sir?
Please.
Yes, please.
So my patient, Miss Shirin Firdaus, a 30-year-old female resident of Ghaziabad, primary school teacher by occupation, was examined by me on the 15th of September 2021 when she came to the OPD with chief complaints of rising serum creatinine and uncontrolled blood pressure for last 2 months. History of present illness. I would like to present the history of present illness from 2018, before which she was apparently well. In January 2018, she became pregnant for the first time. She was a booked case and had regular follow-ups. At 11 weeks period of gestation, during routine investigations, she was informed by her gynecologist that she had some abnormalities in her blood and urine investigations. She remembers that a hemoglobin was low. It was around 9 gram %. Creatinine was raised around 1.4 milligram per deciliter, and urine showed leakage of protein and blood. However, she denies that at that point in time, she did not have any complaint of frothy urine, cola colored urine, swelling of feet or legs, increased blood pressure or shortness of breath, cough, expectoration, hemoptysis, no history of fever, rash, joint pain, oral ulcers, diarrhea or blood in stools, no history of sudden increase in weight. She denied any history of abdominal swelling, jaundice, hematemesis, melena, anorexia, nausea, vomiting, weight loss, headache, seizures, loss of consciousness, difficulty in hearing or vision or discharge through the ears, increased bleeding from any part of the body. She did not give any history of previous pregnancy loss, nor did she have any preceding history of sore throat or skin infection. For the low hemoglobin, she was worked up by the gynecologist and she was found to have a beta thalassemia trait, for which she was told not to worry about. She then consulted a physician, a medicine specialist for her renal problems, who discussed with her the possibility of a kidney disease, problem with the filtration apparatus of the kidney, and told her that she would require a kidney biopsy. She was also told that the kidney disease could be threatening to both her life and to the child, so her pregnancy was of high risk. She repeated her blood and urine tests, which revealed almost the same findings. So in accordance to consultation with the physician and gynecologist, she underwent a medical termination of pregnancy on 25th of February 2018 at 14 weeks period of gestation with 1 unit blood transfusion. The MTP was uneventful and was not associated with heavy bleeding or fall in blood pressure. Around 2 weeks after the MTP, she consulted a nephrologist. She was investigated thoroughly, and the reports that she remembers were hemoglobin was around 9 gram %, creatinine was around 1.5 milligram per deciliter, and urine still showed leakage of protein and blood. She remembers her 24-hour urinary protein was 5 grams of proteinuria. Her ANA was weakly positive, but ANCA and ENA profile were negative, as she remembers. She was told that on ultrasound, her kidneys were still of normal size. And then she underwent kidney biopsy on the 18th of March 2018, which was suggestive of IgA nephropathy. The details of the biopsy report she does not remember. However, on leading questions, she denies any history at that point in time suggestive of inflammatory arthritis. She denies any history of jaundice, abdominal swelling, no history of pruritic skin lesions, pain in abdomen or blood in stools, joint pain associated with skin rash and pain in abdomen. Her blood pressure was also found to be raised at that point in time, and she was started on tablet amlodipine 2.5 milligram OD. For her IgA nephropathy, her nephrologist started her on tablet prednisolone 60 milligram and tablet losartan 50 milligram OD. The prednisolone tablet was tapered over the next 6 months and stopped. Her creatinine after 6 months was around 2 milligrams per deciliter. She was then started on a tablet mycophenolate mofetil 500 milligrams, 2 tablets BD, 2 tablets twice daily. But it had to be stopped after a week because of loose motions. And she was shifted to mycophenolate sodium, 1 tablet thrice daily. She then consulted another nephrologist who stopped Mycept and started her on capsule tacrolimus. She took capsule tacrolimus for the next 6 months, but her creatinine increased slowly to 2.5 milligrams per deciliter, and her BP was also frequently high. Due to increase in creatinine, she visited her old nephrologist again, and she was put on mycophenolate sodium back again. Now she has been on regular follow-up for the last 2 years. Her BP was controlled over the last 2 years, and she gets her tests done. She says that her proteinuria ranges between 500 milligram to 1 gram per day, and the creatinine remained between 2.5 to 2.7 milligrams per deciliter over the last 2 years. Her BP was also controlled, that it was around 130 by 80 millimeter of mercury. However, over the last 2 months, her creatinine has increased to around 3.3 milligrams per deciliter. But she denies any history of vomiting, loose motion, fever, decreased urinary output, dysuria, reddish urine, frothy urine, swelling of body or feet, or any other systemic complaints in the last 2 months. She also denies any history of intake of alternate medicine or painkillers. Her blood pressure is frequently raised in the last 2 months, in the range of systolic being around 150 to 160 mmHg and diastolic being 90 to 100 milligram mmHg, despite taking her medicines on time. But she denies any history of headache, blurred vision, sudden acute rise in blood pressure, shortness of breath, etc. So this is my history of present illness. So may I continue with the past history?
So, Dr. Vivek, I think you gave a pretty good lowdown on what was going on with the history of present illness. So far, like you mentioned, what was the chief complaint that she came into with you on this episode? Did she tell she has this uncontrolled BP and rising creatinine? Was that the main story?
Yes, sir.
Was
Yes,
she
sir.
in for just a second opinion about her current ongoing illness?
Sir, that was also one of the things, but she was mainly concerned about the rising serum creatinine and blood pressure.
Okay. And sounds like she's been a pretty good historian. She gave you all the story about IgA nephropathy, the drugs
Yes,
she's
sir.
been on,
Sir, she
and the
is
course
very,
of illness in the last 3 years.
yes, sir.
Okay. Yeah. Continue, go on. We can come back to a discussion on differentials, but you already had a biopsy on March 20, like 18th March, you said the biopsy was already done. So pretty much the diagnostic dilemma was closed there. So General Verma, like, I don't know, Dr. Verma, would you want to question anything on the history of present illness? Or
Let him finish the past history. Then we come
Sure,
to
sir.
the case. Yeah.
Okay.
Sir, past history, there no history of diabetes mellitus, hypothyroidism, tuberculosis, COVID, renal stones, or any other major illness. No history of any major surgery, apart from the medical termination of pregnancy. Personal history: she was born out of non-consanguineous marriage. She is a graduate in English literature. She was married in 2016. She became pregnant only once in 2018, which was medically terminated. She never tried conceiving again, and husband uses barrier method of contraception. Family history: no family history of similar or any other renal disease. Treatment history: as mentioned in the history of present illness, she is currently taking mycophenolate sodium 1 tab BD, injection darbepoetin, tablet sodium bicarbonate, tablet febuxostat, tablet amlodipine, and tablet calcium. And she received one unit of blood transfusion during her medical termination of pregnancy. So this is my
Very
history.
nice. I think you have given very nice history. I compliment you. Can you summarize it now?
Yes, sir. So a 30-year-old female with no previous comorbidities was detected to have renal dysfunction, proteinuria with active urinary sediment for the first time at 11 weeks period of gestation during her first pregnancy in 2018. She underwent medical termination of pregnancy for the same and renal biopsy subsequently, which revealed IgA nephropathy. She was treated with steroids for 6 months, followed by immunosuppression in the form of mycophenolate mofetil and tacrolimus. She is also hypertensive for the last 3 years. She has now presented to us with progressive rise in creatinine and uncontrolled blood pressure for the last 2 months.
Now, you said the first time the disease was diagnosed when she was 11 weeks pregnant.
So,
At that point of time, you said the hemoglobin was 9 gram, creatinine was 1.4 gram.
so
What creatinine you expect at this time of pregnancy? Was
sir,
it normal?
sir, due to supranormal GFR in pregnancy, we usually expect a creatinine which is the normal serum creatinine ranges between 0.5 to 0.6 milligram per deciliter. And sir, anything more than 0.9 is pathological at that point in pregnancy.
So that means the creatinine, as per you rightly said, was high.
Yes, sir.
Second, you said she had active urinary sediment.
So,
What do you mean by active sediment?
sir, as told by her to me, that her doctor repeatedly said that she was leaking blood in urine. So, sir, presence of RBCs in urine along with RBC cast, though she does not mention it, is suggestive of active urinary sediment.
You are also partly right in that. That means if a person has got significant proteinuria and hematuria, you are justified to call it as an active sediment. Now coming, if you were to see her that time, what was your diagnosis then? She is a pregnant lady. In pregnancy, she comes with this presentation, active urinary sediment. What would you have thought of? And somebody said that possibly you go for MTP. Will that is also justified?
Sir, if I was a treating nephrologist, I wouldn't have suggested her MTP right away. Sir, first after confirmation of, sir, first I would have quantified the urinary protein as well, because in pregnancy, the normal physiological proteinuria increases. So it could be a transient gestational proteinuria also. But
What is the gestational proteinuria? How much is that?
sir, no, a normal person excretes less than 150 milligram of protein in urine per day, but in pregnancy, the upper limit is extended to 300 milligrams per day.
So 300 milligram. So if you had done this, now suppose you have done it, and as you said, the proteinuria was roughly around 5 grams. That was a month later. So we expect that time also there was an active urinary sediment, 5 gram proteinuria. Would you have told her for MTP? You are
No,
a
sir.
physician now. And whether you say yes or no, you have to justify. If I say maybe it is a justified thing, what is the point against?
Sir,
If a person
one
is
of the
eating
very
5 gram of proteinuria, logically you are expecting a glomerular disease.
yes, sir.
If a person is leaking RBCs in the urine, you are expecting an active glomerular disease. If an active glomerular disease, will you like to carry on with the pregnancy and the first time you have found that the creatinine is already 1.5?
Sir, as it is said that the maternal outcome or the predictor of maternal renal function during pregnancy is mainly guided by 3 parameters. One is the serum creatinine, second is the proteinuria, and third is the blood severity of hypertension.
So
As
she had all the 3.
So she did not have hypertension then.
You mentioned you have not given the BP report that time.
No, sir, she had normal BP, sir. I said that she had normal
What do you
blood
mean?
pressure.
What normal BP you expect at 11 or 12 weeks?
Sir, it is the systole. Usually it is around 110 by 70 or
So that should have
in
been
that
the
range.
upper limit of normal.
Yes, sir.
I don't know how much was the blood pressure.
Yes, sir.
What will be your opinion, Dr. Gupta?
Sir, I think I would concur with the opinion given to her to the fact that kidney disease can worsen during pregnancy, and pregnancy outcomes are much worse in patients with chronic kidney disease. You can have IUGR, she has a much higher risk of preeclampsia, she can go into early labor, so there are a lot of complications that can occur in pregnancy with chronic kidney disease, and at the same time pregnancy can worsen the chronic kidney disease itself. The slight
Possibly you agree that maybe MTP was a justified suggestion.
My take on that would be, sir, I would have looked at the body habitus, done a good ultrasound and see how accessible were the kidneys. A kidney biopsy at that time is not really a contraindication.
The second trimester, yes, because she was already 11 or 12 weeks. The biopsy
Exactly.
is
So
in order.
I would have honestly, well, like counted as my bias. My wife is an IVF doctor. So I'm like usually hearing infertility stories all day. So I think fertility and expanding your family is very important. Like if she would have presented to me, then I would have suggested first evaluated the risk for a kidney biopsy at that time. Looked at the anatomy. It's a procedure done in local anesthesia. Not a very high risk procedure if the renal anatomy is okay. Gotten the results, and then maybe sit down and discuss what lies the road ahead to continue with the pregnancy or not. That would be my take on it, sir.
So we will leave that point here. Now go ahead. So this patient had, you said on biopsy, IgA nephropathy,
So,
as per you. And you said ultrasound normal size kidney and proteinuria 5 gram. What you would have expected in the histology? We don't know the histology at the moment. What would you have expected?
sir, on the histology, on light microscopy, I would have expected mesangial cell proliferation along with mesangial expansion. I could have also found some endocapillary proliferation as there was active sediment in the urine as well. Because the creatinine was on the higher side, then some degree of glomerulosclerosis and interstitial fibrosis may have been present there as well. But since the kidney size was preserved, then IFTA obviously would be on the lesser degree, sir.
So right. So what is you expect these features were there because the creatinine was almost in the range of 1.5 or so. These changes you expected at that time. Now, I think we will go to the discussion, but will you like to give anything in the examination at present so that then we can hit the discussion straight away? Anything striking or at the moment you said she presented with rising creatinine and a rising blood pressure.
Sir, examination revealed a very few positive points. Only the thing was she had raised blood pressure when she came to us. Her blood pressure was 170 by 110 in both the arms in supine posture, and there was no postural fall of blood pressure. And sir, fundus examination showed grade 2 hypertensive retinopathy.
Okay.
And she had pallor, sir. These were the only positive findings that I could get.
No edema at all?
No edema, sir.
You can tell the audience also what do you mean by grade 2 hypertensive changes?
Sir, by grade 2, I mean that there was focal arteriolar narrowing and AV nicking, but there was no hard exudate or cotton wool spots.
Whose classification is this?
Sir, it is the Keith-Wagner-Barker classification.
What are the parameters which are taken into consideration?
Sir, there are 4 grades of hypertensive retinopathy. The first grade being there is mild tortuosity and there is generalized mild arteriolar narrowing. In grade 2, as in my patient, there is focal severe arteriolar narrowing and AV nicking, which is the most pathognomonic finding. In grade 3, there is cotton wool spots, hard exudates. And in grade 4, there is papilledema.
Anyway, just keep in mind, it is not one thing what you are saying. You have mixed up everything when you are giving the classification. Whenever you are looking at fundus, first you are looking at the size of vessel. What is the ratio between arteriole and venule? What is the normal ratio? It's 3:4. All right. Then you are looking, if the artery is getting narrow, the ratio becomes 2:4. Once the artery becomes further narrow, it becomes 1:3. That initially 1:2, 1:3, 1:4, then it becomes thread-like. So that is one is the size. Then you see when the light reflection, how is the light reflecting on the wall of blood vessel? Now, whether it is looking like goldish, whether it is looking like silver, whether it is looking like thread, that is another feature. Third feature, what you are mentioning is if when the wall of the arterioles become thick, so that is the time it starts pressing on the venule. And that is the time that if the arterial wall becomes very thick, so the venule gets pressed and there's a nicking. And lastly, what you are saying is the exudation. So don't mix up. So when you are describing look at the appearance, look at the diameter, look at the nicking, and then talk of exudate. And cotton exudates are not a feature of hypertension. That is a feature of diabetes. When you say cotton wool exudate, that means necrosis. Cotton exudate means necrosis. And that is a feature of diabetic retinopathy, not a feature of hypertensive retinopathy. So anyway, she had grade 2 hypertensive changes, BP of 170 by 110 and Pella. That was all.
Sure.
So now she had at that point of time a classical IgA nephropathy. She was given treatment initially with steroids. And whenever you are expecting a proteinuria of 5 gram, how common it is to have 5 gram proteinuria in IgA nephropathy?
Sir, in IgA nephropathy, usually the proteinuria is in the subnephrotic range, but in 10% up to 10% patients, and especially in Indians up to 30% patients, the patient may have nephrotic range proteinuria as well, and sometimes even a nephrotic syndrome.
I won't know 30% if there is any Indian data. Dr. Gupta, what do you feel? Because the figure is much smaller when a person is presenting with nephrotic syndrome. And that is a setting when you have to expect a photocytopathy. A minimal
Definitely,
change.
sir. 30% sounds a bit high to me. It could be one of the IgA nephropathy variants when you're getting
so
some
it is only in the Indian
with
population,
NCD.
actually. It was a...
Okay. Yeah. Maybe you can send us the link to the study, for the Indian data. I'm not sure, but again, it is very rare. The point Dr. Verma is trying to make is nephrotic range proteinuria with plain IgA nephropathy is probably less than 10% of cases.
Yeah, precisely. Because the Western data suggest 1%. If you talk of American data, but we know that IgA nephropathy is much more commoner towards the Asian side. And maybe, as Dr. Gupta said, possibly 5%, 10%, that maybe less than 10% definitely. That is the figure you expected. Now, if there is a proteinuria of this magnitude, do you think the treatment given by the physician, the prednisolone, is in order or no? What would you have done?
Sir, I would have first...
Your approach, if you get a patient like this again today, person is having proteinuria of 5 gram, what will be your approach? How you will go?
Sir, I would first treat the patient conservatively, sir. I would try to control the blood pressure first, ensure some lifestyle modifications like salt restriction, and most importantly, put him on ACE and ACE or ARBs, sir, for 6 months. And then after this antiproteinuric measures and conservative therapy, if still the proteinuria is more than 1 gram per day, then taking into account the risk-benefit ratio and the patient profile, then, sir, I would think of considering immunosuppression. But that would only be after 6 months of this therapy, sir.
Okay. So that means, but maybe 5 gram may not regress with the ACE and ARBs, whatever you are. That's absolutely right. That should be the message given to everybody, that you have to try ACE and ARBs, the conservative therapy as supportive therapy initially. And if the proteinuria is disturbing, like in the patient, you possibly said you will like to give steroids, right? That is it. So which trial, incidentally, where the methylpred is tried and again they found no benefit?
So that was a testing 1 trial, sir. And even in the stop IgA trial, they could not find any improvement in the decline in GFR.
There are some meta-analysis available where you do find that giving steroid does check proteinuria. We do not know exactly what dose should be given or how much time it should be given, but there is data that possibly it may be beneficial in select cases. You cannot say generalization, but possibly Dr. Gupta, what will you feel that in this setting, once a person is having proteinuria 5 gram, and logically, though you have not given us the other profile, what is the lipid profile, what is the albumin level or something, that would have further added the picture. Possibly, do you have any data that what was the albumin?
Not at that time, sir. I have only the current data, sir.
What is the albumin now?
So now it is 3.2 3.2, sir.
Not very bad, not very bad.
Yes,
So it is all right. So because now the proteinuria has also come down.
Yes, sir.
Sir, before we proceed, I had one question,
Please.
Dr. Vivek. So whenever you're dealing with any glomerular pathology, especially now you're having a patient who's presenting with history of IgA. So always, like with other diseases, you should have secondary, reasons for developing IgA in mind. If I ask you the direct question, like what systemic diseases can be associated with IgA nephropathy? You presented a negative history, but still, what specific symptoms would you ask, or what diseases am I asking for? Which patients develop IgA nephropathy more common than other systemic illness?
So the common causes of secondary IgA nephropathy are the most common being alcoholic liver disease. Sir, among the pulmonary system, it could be sarcoidosis. Among the autoimmune disease, it is ankylosing spondylitis, rheumatoid arthritis, reactive arthritis. Among the GI disease, it is inflammatory bowel disease, Crohn's disease. Then there is a celiac disease. Among the cutaneous disease, it is dermatitis herpetiformis, mycosis fungoides. It could be associated with malignancies like bronchogenic carcinoma, lymphomas, or even infections like leprosy and HIV.
So that was very well outlined. You probably covered everything. I would say the three most common things would be the three C's: cirrhosis, celiac disease, and Crohn's.
Sure.
So, and then, angst-pond. Clinically, those are the four top kind of things you see more common. And when you're outlining your negative history, maybe, it's important to run through your mind to ask about these diseases also, so that you make sure. So about the low hemoglobin, you mentioned something in your history. She was positive for beta thalassemia trait. Is that right?
Sure.
If I had to ask you, how is beta thalassemia trait related to kidney disease? What would come to your mind?
So beta thalassemia trait, so I'm not sure if it directly causes any renal disease, but yeah, beta thalassemia, a patient of beta thalassemia trait, if has a coexisting kidney disease, then anemia will be exaggerated. And anemia in CKD is again a predictor of mortality and other important things. So that is what I can think of, sir.
Okay, so the correct answer is beta thalassemia trait is associated with proximal tubular dysfunction. That is what is the renal part related to beta thalassemia. So you could have a full-blown Fanconi syndrome rarely, but you can see the low-level proteinurias, calciuria, magnesiuria, glycosuria, those things can be present. So proximal tubular dysfunction is what can be seen in beta thalassemia. I'm not saying it's very common, but that is the abnormality that is associated with beta thalassemia. I think we can move on to the lab data from now, and then we can go back to treatment like Dr. Verma was asking, what would be your opinion if you saw the patient back in 2018? What would you have done? What trials would support your decision? So maybe you want to go ahead with the lab data that you saw currently, what she came in with, and, then we can take it from there.
So currently when she came to us with a hemoglobin of 9.1 gram%, a TLC of 8,900, a platelet count of 1,90,000 per cubic millimeter. Her serum creatinine is currently 3.5 milligrams per deciliter. Serum calcium is 9.2, serum phosphate is 4.6, and urine protein creatinine ratio is 1.5 grams per day. Her ultrasound reveals right kidney to be 8.3 centimeter, left kidney to be 8.1 centimeter with loss of CMD. And her urine routine examination shows protein 1+, RBC 5 to 10, WBC 3 to 5. So this is her the current reports that she came to us with.
Sorry, missed out on the creatinine. What was the current creatinine
Sir,
again?
3.5 milligrams per deciliter.
3.5. Okay. And the current proteinuria was still 1.5 grams per day.
Yes, sir.
Okay. So, what was the estimated GFR with that kidney function? That level of creatinine?
Sir, it was around 27 ml per minute, sir.
27.
Okay.
Okay. So first, I would like to have your comment on the tried drugs in her. You said prednisolone initially 50 milligram for a duration of 6 months. It was given, long time. And then in addition to losartan, and then she was shifted to MMF and tacrolimus, from tacrolimus back to MMF. Your comment on use of MMF and tacrolimus?
Sir, according to the KDIGO guidelines, none of the two are approved for the treatment of IgA nephropathy. However, sir, certain trials, especially in the Chinese population,
Yeah.
they have shown that MMF could be
Solitary
added
trial possibly, yeah.
as a steroid sparing agent, sir. But it is only not to provide any benefit in terms of progression of IgA nephropathy. It only reduces the steroid-induced side effects in those patients.
And possibly
And
tacrolimus group, it causes further increase in creatinine also.
yes, sir.
So at the moment, as on today, possibly these drugs do not have much role, and one should remain away from them.
Yes, sir.
It's a clearly KDIGO. Does KDIGO mention today about the steroids?
Sir, KDIGO says that if despite after 6 months of antiproteinuric therapy with ACE and ARBs, if the proteinuria is more than 1 gram per day and there is high risk of progression of CKD, you can enroll a patient into a clinical trial and you can discuss with the patient the pros and cons of steroid therapy.
Now, how do you say high risk of progression? If let's say there are 100 patients of IgA nephropathy, what percentage will have high risk of progression, and how do you calculate that?
Sir, there are certain tools, sir. There are certain tools to calculate risk of progression in IgA nephropathy. There are some certain scoring systems. One is the absolute renal risk score, which takes into account the eGFR, 24-hour urinary proteinuria, M from the MEST, S from the MEST, and T from the MEST. One is the Toronto formula, which mainly was used in the Caucasians and the Americans, and that used the 24-hour urinary proteinuria. And so there is also an absolute renal risk score. So there's an international IgA nephropathy prediction tool as well, which has around 11 to 12 parameters. But sir, none of them can be used as a guide whether or not to use immunosuppressive therapy or not.
That's all right. It is only giving you a prognostication whether the disease is progressive or not.
Yes, sir.
As you rightly said, that does not mean that if the risk score is high that you have to use immunosuppressive therapy. But as you rightly said, there are many scores which take into account all the parameters, right from race up to age, to your blood pressure, to your proteinuria, to your eGFR, to your biopsy criteria, and putting all together, it gives you that possibly in next 5 years, how one is going to progress. And if the progression rate, in generality, if you want to ask me, 30 to 40% of patients have progressive disease. They have got moderate progression. Possibly another 60% may not have, they have a mild disease. But those with progressive disease, that is what the KDIGO recommendation remains, that is a group where you can individualize a patient and possibly can use steroids if you feel so, explaining all the risk and all that. So there's no place for MMF or tacrolimus, what you are doing that. Now, at this stage, what do you want to advise? You say at this moment, she has come to you, and she has come to you with a creatinine of 3 point something. So that means GFR of whatever, 25 or 27, you said?
Yes,
she's
sir.
hypertensive. Logically, anybody will say she has got high risk. She has got a bad disease that way. It's a progressive disease. And if you were to do biopsy, you will find a lot of IFTA and glomerulosclerosis. The jump is not that profound. You mentioned that creatinine was remaining 2.5 to 2.7, and now it has, that is a 2-year history. Now it has come to 3.3. It's not a very strong jump, are not associated with any hematuria, gross hematuria, something to say that possibly crescents would have developed. But if a biopsy is done, what percentage of patient you feel will have crescents?
Sir, less than 10%.
But if you're looking at the progressive disease people, the risk of the incidence of crescents is much higher.
Yes, sir.
If you are taking in generality, then possibly the crescent will be less. But if you're looking at patient with a progressive disease, then possibly, yeah. So how will you manage her now?
Sir, right now, first of all, I would like to stop her current immunosuppression, because it is clearly has not done any benefit to her. It has clearly not retarded the progression of her disease.
She's still on steroids or something?
No, sir, she's on MMF only.
Okay. Oh, she's still on MMF.
Yes, sir.
Okay.
So, sir, I would like to stop her MMF first. Secondly, sir, I would like to maintain a strict control of blood pressure. I would like to hike up her antihypertensives. Thirdly, sir, if I could keep a check on her serum potassium, and I could counsel her regarding her potassium intake, then I would like to add an ACE or ARB in my antihypertensive regimen, sir. Apart from that, I would also like to correct her hemoglobin. It is on the lower side. So as she's already on the erythropoietin injection, on darbepoetin injection, so I would like to review her anemia profile, and if there is any scope to correct any parameter in the form of B12 deficiency or folic deficiency or iron deficiency, I would like to correct that. Sir, as she is already in the stage G4 of CKD, I would also like to add a sodium bicarbonate tablet, which she's already taking. Then, sir, any other comorbidities if she has, so I would like to take care of that, sir. But I wouldn't want to do any active intervention right now, sir, in the form of any immunosuppression.
So that's what you are saying, as you will manage any other chronic kidney disease patient.
Yes, sir.
The point which you rightly mentioned, that one has to keep in mind that do not be very much scared of ACE and ARB. Probably we are underutilizing their benefit, and we get scared of hyperkalemia. I'm not saying we should not get scared of hyperkalemia. We should keep a check on hyperkalemia, and with the possibly shortly availability of hyperkalemic medicines in India, possibly we should be a little more liberal also for giving these drugs. And many of us are using it till the dialysis time also. And we did once a study long back, and where we gave to all our dialysis patients ACE and ACE or ARBs, and approximately 18 to 20% only develop hyperkalemia. It's not a very, very threatening condition. Keep a watch on that. But the benefit of that at the moment should not be deprived with the. What about the, Dr. Gupta, if he wants to ask anything now, then we ask him about dapagliflozin also. You can talk about that.
No, sure. My question was going to be, like, I think when you're treating, so like Dr. Verma said, IgA nephropathy is one of those conditions where you really have to hold your horses, Always you're going to see active sediments, you'll see blood, proteinuria, rising creatinines. But again, this is one of those diseases where you have to know what is the role of immunosuppression, what is the data available for assessing each agent individually. Like if I was to ask you, Dr. Vivek, broadly, there are 4 agents available for any GN. Steroids, MMF, tacrolimus, endoxin, and rituximab. If I had to ask you endoxin and IgA, what do you think? Is there any role or somewhere you're going to use it?
So only in crescentic IgA nephropathy, sir. If it's a crescentic IgA nephropathy, then I would use endoxin, sir. Otherwise, not.
So, I would add the word rapidly progressive renal failure also with that. So if you're seeing a lot of crescents with rapidly progressive renal failure, then yes, endoxifen should come to your mind. You already mentioned the part MMF was found to have some evidence only in a Chinese study. When this tried to do it outside China and other patient groups, it wasn't really successful. How about CNI or rituximab?
Sir, CNI also are currently not recommended by the KDIGO. Sir, they could CNIs again. Sir, they could reduce proteinuria they could reduce proteinuria by their physiological mechanisms, but they do not retard the progression of IgA nephropathy. And so same goes with rituximab. So rituximab also was used in a pilot study, but again it showed no benefits.
Sure. So yeah, rituximab, there's only like case study level data and case reports. So not really something that you should use regularly. Two other distinct agents that may have some role in IgA, or one, that big Mayo study, which we give it to many patients clinically in our daily practice.
So fish oil.
Yes. So fish oil is again something you have to counsel the patient about the high dose that was used in the study. What was the dose?
Around 12 grams, sir.
Yes. So clinically taking that dose gives you a lot of GI side effects, almost, fish-like smell in your mouth, bloating, abdominal pain. Most patients will not be able to tolerate it. But sometimes, you can counsel the patient and start them on a fish oil. What else?
Sir, again, fish oil has not been recommended by KDIGO as a part of the standard therapy. And sir, apart from this, tonsillectomy is a part of the local national guideline in the Japanese population, and they routinely perform it. But it is not recommended in other populations by the KDIGO as well, sir.
Yep. So tonsillectomy only in Japan, not really a standard of care in other parts of the world. The one drug is hydroxychloroquine, Plaquenil.
Yes, sir. Hydroxychloroquine is also being studied currently, mostly in the Chinese population.
Yes.
As a steroid sparing agent.
Yes, exactly. Yes, yes. And what was the big study on steroids in IgAN that actually showed significance, with some positive results as well as negative results, but it was terminated early?
So there have been 4 studies in IgA nephropathy on steroids. The first was a stop IgA nephropathy trial. Then was a testing 1 trial, which was stopped at an earlier stage due to overwhelming side effects. The testing low dose study is still ongoing. And then we had a phase 2B study, which was the Nefigan trial, which was of the targeted release budesonide preparation.
Yes. So testing the steroid arm did show some benefit on the arm it was used, but it was terminated early. I think they planned somewhere around 700, 750 subjects, but they had to stop around 250, 300 because they had a lot of adverse events. So again, glucocorticoids that is probably the only thing that works for IgA nephropathy, but you have to again keep in mind all your contraindications, like in other cases, uncontrolled diabetes, obesity, latent infection, active peptic ulcer disease, bone disease, severe osteoporosis, uncontrolled psychiatric illness. So those contraindications common to all glomerulonephritis apply same here. Next, again, I think when we talk about IgA nephropathy, everybody, like when you go to an international conference, they want to talk about novel agents or drugs that are being studied. So tell me 3 or 4 things, people have been trying their hands on for the last decade or so to come out with a, new drug for IgA. What all comes to your mind? At least 3 or 4 agents that have been given a trial. You mentioned like tonsillectomy 1, then you mentioned something about budesonide. Expand on that.
Sir, budesonide, the targeted releases budesonide was basically, so it came into vogue because we wanted to go away from the systemic side effects of steroids. So a steroid agent that could act specifically at the terminal ileum, at the region of the Peyer's patches, which is a very big host of the plasma cells that produce the poor galactosylated IgA in the IgA nephropathy. So that is why, sir, budesonide came into vogue. And it was studied in Nefigan trial. So other new agents that are being studied currently are, so one is a atacicept. It is a monoclonal antibody against the TACI receptor on the B cell. Sir, then we have a monoclonal antibody by the name of WIZ649. It is an anti-APRIL antibody, anti-proliferating inducing ligand. So then we have as the role of local complement activation is also important in IgA nephropathy. We have the iptacopan, which is the alternate complement pathway inhibitor, and we also have the narsiplimab, which is the MASP2 inhibitor, and it inhibits the lectin pathway. So these are the current drugs under study.
You
Right.
read up on your IgA quite well. The phase 3 protect study, the sparsentan, that's also one of the drugs.
Sparsentan is also being studied, sir.
And then coming to the new wonder drug, the analogs of ACRB, SGLT2. Dr. Verma, would you please want to question him?
No, I think, yeah. He has mentioned most of the new drugs. You have commented on April, you have commented on BAF, the antagonism of these drugs. I think they are the future drugs, if they are coming, because though we have not gone to the pathogenesis, but how the disease occurs. And if you are able to target at that point, that will be wonderful. And that one has to look for that. What about the dapagliflozin? Your comment on that?
So the a subgroup analysis of the DAPA CKD trial showed that around 270 patients enrolled in the DAPA CKD trial were having IgA nephropathy, and dapagliflozin in them did reduce the proteinuria as well as the disease progression IgA nephropathy as well. So, sir, this retrospective analysis has shown a lot of promise in dapagliflozin, and currently it is being studied.
You say that there is no head-to-head straight trial comparing the drug, but if we go by whatever data is available, and that is not only for IgA, that is for all non-diabetic kidney disease, that DAPA is useful. And possibly these are the drugs. At the moment, in 2021, what you can try is only ACE, ARBs, and possibly DAPA. So these will be the only drugs. And as Dr. Sagar was mentioning, that possibly the newer glucosinide and targeted therapy, that is a big requirement, because actually there's nothing. If you look at IgA nephropathy, barring ACE, ARB, there is nothing which is effective. You say the steroids are not effective. This is the only disease where nothing else is effective, barring ACE and ARBs, and being the commonest disease. So there is high time we have to have some targeted therapy, which should be able to bring that. Anything, Dr. Sagar, we are missing in that? He has mentioned that we have covered that how to suspect IgA nephropathy, that a person presenting with previous times when we used to say that why the hematuria is occurring. Any thought? When a person has got microscopic hematuria, what does it mean actually? How it is occurring? There is microscopic hematuria. Rather, if a person presents to you with a macroscopic hematuria, well, what is your DD? Sir, this patient is not present like that. But if he comes with a frank hematuria.
So if a patient comes with a frank hematuria, I have to consider some non-pathological causes and some pathological causes. Some non-pathological causes could be an exercise-induced hematuria. Then, sir, I have to exclude certain drugs that can cause reddish urine that can be confounded with hematuria, like pyridine, nitrofurantoin, etc. Sir, then among the pathological causes, the causes could be divided into glomerular causes and non-glomerular causes. So among the glomerular causes, the very important ones are the IgA nephropathy. Then among some inherited causes, there could be thin basement membrane disease. There could be Alport syndrome. Sir, among infective causes, UTI is a very important cause of gross hematuria in adults. That then other non-glomerular causes could be autosomal dominant polycystic kidney disease. There could be nephrolithiasis. There could be renal cell carcinoma, renal papillary necrosis.
Right. So if a person is presenting to you like with hematuria, what is the way you will deal with him, investigation-wise?
Sir, if
that is a common way of presentation. And why actually macroscopic cross hematuria occurs in IgA? One is a microscopic, you say there's an endocapillary proliferation. You can explain that. But what happens for macroscopic? Many people have got attacks of this. Like in children, there can be vasculitis, which could be responsible. But in adults, why it is occurring?
Sir, so the first question, how we approach hematuria. Sir, first we have to ensure that it is a significant hematuria. So there must be more than equal to 5 RBCs per high power field on at least 2 out of 3 occasions. If it is
3
so,
out of 3 occasions, not 2 out of 3. All the 3 occasions it should be there.
okay, sir.
Yeah.
So then we classify it into glomerular and non-glomerular hematuria. If it is associated with proteinuria more than 2 grams per day, if it has dysmorphic RBCs, if it has RBC cast, if it has acanthocytes, these lead us to glomerular hematuria, and absence of these lead us to non-glomerular hematuria. And sir, we investigate accordingly. And sir, why gross hematuria occurs? So in IgA nephropathy, especially in the younger age group, the most important finding is a mesangial cell proliferation. And so the mesangium, as we know, acts as a anchor to the cytoskeleton of the filtration barrier. So when it is deeply inflamed, and when due to inflammation, the cytoskeleton structure gets altered, and so there is leakage of blood from the vasculature into the urinary space. It only occurs when, sir.
So that's how you feel it is due to mesangial proliferation. And that is a destruction of the architecture holding up the capillaries. Because if you go to the previous literature in our times, they used to say that it only reflects crescents developing. But now possibly that thought process is going. The previous literature used to be, whenever you are having macroscopic hematuria, if you go to KI, Kidney International, they'll say possibly there is an infarct, there's a crescent developing, there's a rupture of the capillary, glomerular capillary. That is how the gross hematuria is coming. Anyway, so that is another food for thought, that how it occurs. You also told us that evaluation. So for hematuria, how will you evaluate investigation-wise? One, you said you have done urine. You have checked that it is a glomerular or non-glomerular pathology. If it is a glomerular, possibly you will go for biopsy. But if it is a non-glomerular, possibly cystoscopy will be in order after the imaging investigation. So, Dr. Sagar, anything you will like to address in what you have addressed today so far, that the presentation of IgA nephropathy can be very varied. It can be asymptomatic hematuria. It can be incidentally picked up. Many cases get just incidentally picked up. And it can present with macroscopic hematuria. And whenever a person is presenting with macroscopic hematuria, you have to think, especially the children present early because of macroscopic hematuria, because of the vasculitis. So that Burgess disease, what you call. So that is an early pickup and early diagnosis. Otherwise, the diagnosis may get delayed. Now, should we worry, what I'm asking you? We say it's a very common disease. If you look at the data, in US, 10% of all glomerular diseases are IgA. You go to Europe, it is 20 to 30% of all glomerular diseases are IgA. You come to Asian countries, 40 to 50% are because of that. Now, are we worried? Is it progressive disease? It gives rise to end-stage kidney failure? Because my two comments now will be that questions to you will be, now this lady progresses and she asks for transplant. What is your take on transplant, and what is your take on recurrence following transplantation?
Sir, as in the natural history of IgA nephropathy, usually, sir, there is a decline in GFR of 1 to 3 ml per minute per year, and approximately 15% patients of IgA nephropathy reach ESRD by 10 years, and 25% patients of ESRD reach ESRD by 20 years. And around 20 to 30, sir, as you mentioned, they have progressive decline in kidney function. Sir, regarding the transplant, sir, if the as the patient reaches ESRD, so we can very well counsel her for renal replacement therapy in the form of a transplant. Sir, the only things we have to keep in mind about the higher recurrence rates of IgA nephropathy in transplant, though the recurrence is around in 20 to 30% patients, that too after 3 years. But graft, that is the histologic recurrence, might be in 30 to 40% patients, but graft loss is quite uncommon until 3 years. And sir, the post-transplant, I mean, the recurrent IgA nephropathy in the graft also behaves like the native IgA nephropathy. So if it was a rapidly progressive IgA nephropathy leading to graft loss, leading to the native kidney loss, then a higher chance of recurrence in the transplant kidney as well. If we have a living related donor, confers a higher risk. Some HLA types like HLA-DR3, HLA-DR4 also confer higher risks. If the patient was earlier withdrawal of steroid therapy post-transplant, can confer higher risk. So these are the...
What precaution you want to take if a person receives transplant now? Any precaution you want to advocate. It should not be a steroid-free protocol. Because normally you can go for steroid-free protocol. As you mentioned, the recurrence rate is very variable, depending on when you have, how severe was the disease, what is the HLA match, what is the disease progression prior to that, what is the sex, what is the ethnicity. There are many variables. That is why there is a lot of variability in recurrence rates. But precaution, do not have steroid-free immunosuppression in these patients to prevent, because if the DSA is high, the recurrence rates are high. And keep in mind that patients who develop IgA nephropathy, the graft loss is 3 to 4 times higher in those people. That is there. I think there's a beautiful article which has come on recurrence of IgA nephropathy this month or last month in JASN. And that only is covering a large population where people have developed recurrence after IgA nephropathy. He's given a lot of risk factor, who are the people who develop it. It will be worth reading that. Dr. Saad, anything we are, Dr. Sagar, your comments now.
My question, like for you, Dr. Verma, like what would you have done, what we were discussing originally, if she presented to you at 14 weeks? Would you have gone the same route she went?
Very tricky question, but possibly if it was a progressive disease and in pregnancy, if a person is having significant high proteinuria, it may be a risk factor. I remember I had a lady of FSGS. She was having 8 to 10 gram proteinuria. She was bloated up. So I advocated her that you have to have MTP. She refused. She said, "Doctor, मैं आई आपके पास इसलिए हूँ कि I want to carry on pregnancy. अब करिए जो करना है." I do not know how many albumins we gave her. Her albumin was 1.4, 1.5 gram. I was always scared. And she had initial follow-up in AIMS. So I kept her till 27, 28 weeks with giving albumin. I put her on tacrolimus that time. That is the only thing we can give her in pregnancy. Fortunately, she got hospitalized in AIMS by 28 or 29 weeks. And she had a fruitful delivery at 36. So you have to take a lot of risk. If a person is keen that he listens to you like this lady, that MTP, yes, I can go ahead. But if a person is not keen, if it's a very precious delivery, possibly I may carry on with some therapy. I don't know what would have been your take. Yeah, because there is no straight answer we can say that.
Definitely, sir. It has to be. Yes.
Yeah.
Doctor-patient discussion about the pros and cons. And then often, we have to involve patients in such decision making. What really, is important for them and what do they want to choose. Dr. Vivek, we've discussed briefly on kidney transplant. Suppose, God forbid, she goes into ESRD in the next 2-3 years, and then she's had a transplant. So we're talking about kidney transplant and pregnancy in general. She comes to you, she's 36, 37, she's had a kidney transplant and asks you, doctor, now I want a baby. So how are you going to start the discussion? What are the medical things you're going to look at?
Sir, counseling a renal allograft recipient for pregnancy, sir, I would advise her to plan pregnancy at least a year after the transplant, so that she is stable on her immunosuppressives, her graft function is stable, and preferably before 2.5 years after transplant. So the ideal time would be between 1 and 2 years of the transplant. Sir, before planning her pregnancy,
why before 2 years? Sorry, why before 2 years?
So articles say that it is the highest chance of fertility is in during that time, because after that maybe chronic allograft a component of chronic allograft nephropathy would seep in, and her chances of having a successful delivery decreases progressively.
I'm not sure about that, but I think the American guidelines recommend you have to wait at least 1 year, and then the European guidelines recommend preferably wait around 2 years. So I think beyond 2 years also you can counsel them. But I think overall you're right. So first is the timing. Then what next? She's had a
Sir,
transplant. She's sitting in front of you. Yeah.
Sir, I would convert her medicines to a pregnancy-friendly regime at least 3 months before her planning, her conception. So I would continue with the cancelurine inhibitors. I would convert my MMF into an azathioprine, and I would continue with the low dosage of steroid. Sir, I would also start her on a folic acid. Then I would ensure a strict control of blood pressure, because she could have a higher risk of preeclampsia as well. So, and I would not change the levels of my CNIs too frequently, because the trough levels might be confounding in pregnancy because of altered water status and altered protein binding. And sir, I would ensure a more stringent follow-up with her. So this is what, sir, I would think of. I would monitor her proteinuria, monitor her creatinine, monitor her blood pressure quite often.
Okay. So remember, if in case she wasn't on ACE or ARB, you have to stop
Yes,
that
yes, sir.
also.
Yes,
You
sir.
rightly
Yes,
mentioned stopping the MMF, changing it to azathioprine. Continue with the CNI, azathioprine, and steroid. And how about the TAC? Like suppose she's on tacrolimus. What do you think about tacrolimus levels in pregnancy? How do they fluctuate, and what do you need to keep in mind?
Sir, the tacrolimus levels can be due to altered protein binding and increase in total water content of in a pregnant woman. So unless the tacrolimus levels are very low, I wouldn't want to change them much. Sir,
So yeah, with the expand in volume and there's a rev up of the cytochrome P450 pathway, your TAC levels usually go lower. So like you mentioned, when you're keeping her in close follow-up, make sure you get more frequent trough levels, and you may have to go up on the dose anywhere from 20 to 30% if you're talking about tacrolimus, because that is the kind of dose increase you may need in pregnancy, again with the expansion in volume and with the revving up of the cytochrome T450 system. So I think you've pretty much touched on most of the things that you have to keep in mind. And again, you have to keep IgA nephropathy recurrence in mind, and that is going to need a kidney allograft biopsy. There are no real blood or urine markers, whether it is native kidneys or transplant kidneys, that we have so far to predict IgA or to predict IgA recurrence post transplantation. Dr. Verma, anything else from your side?
I think that should be adequate after covering this, and I must compliment this presenter Vivek. Very well done. I think you have come very well prepared.
Very well done. Yes, very well prepared.
Case
Well
was
read.
straightforward. It was rather, it's not, yeah. I think we can stop here, and thank you very much, Dr. Sagar, for immense
Thank you, sir.
contribution to him. And I wish we could have participation from students verbally, but that is not there. So we close it today. Thank you very much.
Thank you, sir.
much,
Thank you
sir.
so much.
Thank you, Dr.
It is
Thank you so
always
much, sir.
academic feast to have you.
Thank
Thank
you
you,
very
Dr.
much.
Sagar.
Thank you, Puneet ji.